exception of New Zealand. What I wanted to talk to you about today is new concepts in myopia management. So when I was discussing this lecture with Fethu, we talked about various topics, and what I've decided to do is to talk about 4 topics in particular to take you through some new concepts in myopia management. So I'll just share my screen now and get my slides up and available. Okay, so hopefully you can see my screen now. Excellent. And I know my voice is working because it's 4:30 in the morning here, so we are ready to go. Okay, so I mentioned that I wanted to talk to you about new concepts in myopia management, and these are the 4 that I'll take you through over the next 40 minutes or so. How can we communicate the benefits of myopia management treatment? Which treatment works best? Very important question. What are these new spectacle lens designs? There's been so much development in this area just over the past few years, so it's important we understand them. And the newest topic potentially on the block is red light treatment. So have you heard about that new red light treatment? If you haven't, I'll tell you some more about it and give you some direction to further reading today. So let's start with number 1. How can we communicate treatment benefits? Now, if you have come to have an understanding of myopia management, it's likely that what you understand most is this long-term eye health message, the ideal message, the message that's probably really grabbed us as eye care professionals is that myopia increases eye disease risk. And so if we can reduce someone's final level of myopia by reducing myopia progression, then we're reducing their lifelong risk of eye diseases and vision impairment that happen with higher levels of myopia. But this is a very long-term, a very far away message. So perhaps there is a better short-term message about the short-term benefits of myopia management than we can talk about with parents and with patients. And to illustrate these short-term benefits, I'm going to use the example of Olivia. We're going to imagine Olivia at age 7 and then again at age 8 in 2 different scenarios. So Olivia at age 7 is -1. And if we correct her with single vision spectacles, then over the next year, the average amount of progression for a child of her age and ethnicity is around 1 diopter. So if she comes back to us in 1 year, she will be likely to have progressed in those single vision spectacles from -1 to -2. If instead we prescribed a treatment for Olivia which slowed her myopia progression by 50% or by about half, and I'll keep that in mind, about half, I'll talk about that later. Instead of progressing 1 diopter in a year, she's likely to have instead progressed half as much, so half a diopter in a year. Now let's think of that for a moment in terms of what her visual experience might be across that year. If Olivia presents to us with glasses that she got at age 7 that are now 1 diopter undercorrected, she's likely to present to us with acuity of around 618 or 20/60, and that actually meets the criteria for vision impairment according to the World Health Organization. Now, we know that Olivia isn't visually impaired because we can fix this. We can increase the power of her glasses, but she's experiencing visual acuity equivalent to visual impairment levels. Whereas if we had prescribed a myopia control treatment and she'd progressed by half as much, and she's wearing glasses that are only -50 undercorrected, her presenting acuity is likely to be around 6.9. Now, that's a very different experience for a child being 6.9 compared to 6.18. And even though we don't know exactly when the progression would have happened, we know that she has spent some time during that year between eye exams suffering this poor acuity. Now, if we understand the short-term benefits, then we can follow that up by understanding the long-term benefits. And this was an important report which analysed the risk of myopic maculopathy right across the refractive range. And it found that there is a difference between being -2 and -3. there is a difference between being -5 and -6, because each additional diopter right across the refractive range increases the risk of myopic maculopathy by around 60%. If we flip this equation, this means that if we can save a patient a diopter, if we can reduce their final level of myopia by 1 diopter, this reduces their lifelong risk of myopic maculopathy by 40%. Now, we know we can't make someone less myopic. Once their eyes have grown, their eyes are that length. We can't shrink eyeballs, except maybe with red light therapy. Much more on that later. But what we're talking about in saving 1 diopter is reducing progression by 1 diopter compared to what it could have been. And we have treatments that can achieve that in a short period of time. And I'll tell you more about that later on. So I would argue that with myopia management, we are reducing the risk of vision impairment. These are the World Health Organization criteria for visual impairment. And even if we leave a young child undercorrected or uncorrected by 0.75, that's going to give them the sort of acuity that means they're experiencing temporary visual impairment. So the short-term benefits of myopia management are avoiding temporary visual impairment or the experience of that between eye exams for kids because they have slower myopia progression. And then the long-term benefits are reducing the lifelong risk of permanent visual impairment, which is likely to increase with higher levels of myopia. Now, it's important we think about how to communicate this to parents. And I think it could be as simple as this. We can say that the short-term benefits of myopia management is that your child will spend less time with blurred vision between eye exams with myopia control. Instead of their refraction changing and their vision worsening every 3 to 6 months, it might take 9 to 12 months. And that's a simple message, but a strong message because it includes important parts of the message, such as we can't stop myopia progression, but we can slow it down. And then once a parent and a patient understands what the very real short-term benefits are of myopia management, we can follow up with the long-term benefits that myopia control can also reduce your child's lifelong risk of eye health and vision problems, which can occur in adulthood. So we can talk about the benefits now as well as the benefits in the future. Now, that's ultimately designed to help you with clinical communication. In this next section, when we talk about which treatment works best, I'm going to take you on a little bit of a nerdy scientific adventure through our understanding of myopia control treatments. To do that, we need to think about which treatments have been investigated for myopia control, and there are many treatments that have been investigated. There are a variety of spectacle lens designs, contact lens designs, different concentrations of atropine, and different levels of light therapy. So there have been red light therapy, which I'll talk about later, and then violet light emitting and violet light blocking glasses. So they're a little bit more unusual. What's far more usual and far more commonly available to us are our spectacle and contact lens options. And to explain what the little infographics mean on the slides there, if you have a look at the spectacle lens options on the left, up at the top, we have the dim spectacle, the defocus incorporated multiple segments. So that's the Hoya MyoSmart. Next, we have our concentric lenslets, our highly aspherical lenslet target technology. That's the Essilor Stellest. And underneath that is the sight glass dot lens, which works in a different manner to lenslets, works with diffusion technology, and I'll tell you more about that later. Underneath those, we have bifocal and progressive spectacles. And down the bottom, we have a peripheral defocus spectacle. And that was commercialized quite a while ago by Zeiss as MyoVision. Now, in the middle, we have representations of various types of contact lenses. The first is an extended depth of focus lens. The second is our CooperVision MySight One Day, so dual focus concentric. Then underneath that, we have, I'm not sure if you can see my mouse there, but I'm just pointing to a representation of a center distance multifocal with a 250 ad. So that's the bioaffinity center distance with a 250 ad has been shown to have a small myopia control effect or moderate. And then next to it is a different soft contact lens with ring boost technology, which is the new Johnson & Johnson Vision AccuView Ability one-day lens. Underneath that is Ortho-K. All right, so let's get into understanding how these treatments work. And what I'm actually going to do is take you on a little bit of a journey through talking about myopia control efficacy 3 different ways. And this is something that's still under discussion in the literature. And this is really a cutting edge of myopia management, is us understanding how we can describe efficacy. So we're going to look at the scientific point of view. And then, of course, as I always do, and as we do at Myopia Profile, bring it into the clinical translation. So we can understand myopia control efficacy talking about millimeters, so how much reduction in growth an eye has in a treatment. We can talk about efficacy by discussing which treatments will save us 1 diopter, because remember, saving 1 diopter of progression reduces that patient's lifelong risk of a variety of eye diseases, myopic maculopathy, glaucoma, retinal detachment, and posterior subcapsular cataract. Or we can describe efficacy with percentages. So let's have a look at each of these in turn. The first way I'm going to describe efficacy for you is reduction in eye growth. And everything that's sitting in the green box there is a treatment that has shown reduction in eye growth by at least 0.1 millimeters per year. Now, this matters because we know that young eyes are meant to grow anyway because of emmetropization. Up until around age 12, eyes are meant to grow by about 0.1 millimeters per year. But a myopic eye grows by 0.2 to 0.3 millimeters per year. So if we can slow eye growth by at least 0.1 millimeters per year, we're reducing that myopic eye growth rate, that speedy rate, back to closer what the emmetropic eye growth rate is. And all of the treatments in the green box have shown the ability to slow eye growth by at least 0.1 millimeters per year. So we have our new designs of myopia controlling spectacles up the top, the DIMS lens, Hoya MyoSmart, our Holt technology, which is Essilor Stellest in the middle, and the sight glass dot lens, so diffusion optics technology. We have contact lens options. We have our MySight One Day. We have the ring boost technology, which is the J&J Ability lens. It's got an asterisk next to it because we only have 6-month data published. But based on the 6-month data, it looks like it would jump that line and it would slow axial growth by 0.1 millimeters in a year. And Ortho-K also meets that criteria. We have varying concentrations of atropine and red light therapy. But if we focus on our optical treatments, you can see how we've got treatments that are reducing that axial eye growth closer back to what an emmetropic rate of eye growth is. This is our second way to describe myopia control efficacy. And even though it's a different way to talk about it, you'll see that the winners are still quite similar. The treatments that are top tier, top of the pack, are similar to the previous message. Now, this is a way to talk about efficacy when we're talking about treatments which have been shown to save 1 diopter, but we're going to use the millimeters equivalent. So the millimeters equivalent of 1 diopter is about 0.25 millimeters. So all of the treatments on this slide have been shown in their studies over only 2 to 3 years to be able to reduce eye growth in the treatment group compared to the control group by at least 1 diopter equivalent in millimeters. So again, we have our myopia controlling spectacles with lenslets. We have CooperVision MySight, which is our concentric dual focus. We have Ortho-K, 1% atropine, and red light therapy. But both 1% atropine and red light therapy get an alert because we've found significant rebound effects with these treatments. So rebound is where you stop the treatment and the eye grows faster than what it would have if it had just been in a single vision correction. And rebound effects are concerning because we don't want accelerated eye growth. That could be damaging to the retina. So see, we still have our spectacle and contact lens options, which you saw in the previous slide. And then we have treatments which are likely to save 1 diopter once we get a little bit more data. And that's 0.05% atropine, the diffusion optics technology, the sight glass dot lens, or the J&J Ability lens. If we have longer studies with more data, these will probably also jump that barrier of saving 1 diopter. And saving 1 diopter just in quite a short term, just over 2 to 3 years of the studies. So again, this green box stands. We have our top tier of treatments sitting in these green box. And hopefully when you're looking at that top tier of treatments, our best in class, you can see at least 1 or 2 or maybe 3 of these that are available to you now in practice. Now you might be thinking, well, if we can get 1 diopter in 2 to 3 years, could we get more than 1 diopter? We may never have the randomized controlled trials that are long enough to tell us this precisely, because once a treatment starts working well, after 2 to 3 years, it becomes unethical to continue the control group. So in these studies, what's happening is the control groups get to 2 or 3 years and they are then given the treatment because that's the ethical thing to do. So the only way for us to know this at this stage is to use modeling. And the modeling takes the progression we would expect to see of a child with myopia. So if you think of that as a virtual control group, and extends it over a longer period. So modeling presented at the ARVO Research Conference in 2021 and this year in 2023 has shown firstly that the MySight lens could reduce myopia progression or could save us potentially 2 diopters over a childhood of contact lens wear from age 8 to 18. And the Essilor Stellest lens could save almost 1.5 diopters over 4 years, which looks like it could be heading towards 2 diopters over a longer period of time as well. And if we can save 2 diopters, then we're saving our patients 40% plus 40%, that reduction in risk of myopic maculopathy. So we have very powerful treatments available to us that can achieve very significant effects just within 2 to 3 years, and probably more if we continue for longer. Now, a third way that we can describe myopia control efficacy, and what I think is perhaps the easiest way to explain it to parents and to patients, is to talk about percentages. But the thing we have to be careful about with percentages is that a percentage within a study is an important number. It shows us how well the treatment has worked compared to the control group, but that percentage is only valid and only belongs to that study. We can't compare percentages between studies and say that 67 is better than 59 is better than 52%, because the percentage is influenced by the duration of the study, by the age and the characteristics of the participants of that study. So I would suggest that instead we can think of percentages as categories. So instead of thinking about 52 or 59 or 65%, we think about categories of treatments. And this is an easy way for us to then communicate myopia management to parents. So how can we think about percentages as categories? If we think about these top tier of treatments that I've shown you in 2 different ways are reducing axial eye growth by at least 0.1 millimeters per year, and are also saving us 1 diopter of myopia progression just within the short term of their studies. What these treatments have in common that are sitting up at the top of the podium there is that in all of their studies, they were shown to slow axial eye growth by at least half, or at least 50%. So this is a nice simple message. And up at the top of the podium there, we have MySight, we have Ortho-K, we have our myopia controlling lenses, which I'll talk about in the next section, and atropine 0.05, that were all shown to slow axial growth by at least 50%. So we can say very simply that these can slow progression by at least half on average. And that's a very clear message for parents. That's a powerful amount, half, but it also says we can't stop myopia progression. In second place on the podium, we have treatments that have been shown in their studies to slow axial eye growth by about a third, about 33%. That might have been 30 or 37%, about 33. And those are extended depth of focus contact lenses, which is the Mark-Enevy Milo or SEED lens. We have the center distance multifocal with a 250 ad, so the bioaffinity center distance, atropine 0.025%, and bifocals and prismatic bifocals. These slow progression by about a third. Then in the third place on the podium, we have our least effective treatments, which are progressive addition lenses, peripheral defocus spectacles, and atropine 0.01% as a monotherapy. So if you have anything available to you on the top tier of that podium, and most of us have at least one thing available, then you have a top tier treatment, which has been shown in its study to slow progression by at least half. So which treatment should you prescribe? Any of these which you have available to you, because there isn't any indication that one treatment is better than the rest. In fact, the indication at the moment is that a lot of treatments appear to have similar and very good efficacy. So prescribe anything out of these categories that suits that child and it fits your scope and setting of practice. And as an optometrist myself, it makes complete sense to me to prescribe optical treatments first. In Australia, I can prescribe atropine, but it's not necessarily my first choice when I can prescribe an optical treatment which both corrects myopia as well as controlling myopia progression. And we have a lot of tools in our toolkit to select from if we're thinking about these top tier of treatments, these ones sitting at the top of the podium. Now, Paul and I did some research. We presented at ARVO, the Global Association for Research in Vision and Ophthalmology conference each year, where we compared treatments in a different method and using direct comparisons. And we actually found that most treatments with at least 12 months of clinical data did show similar efficacy, with some being less effective. And the less effective were the ones which you saw lower down on the podium. So this was essentially a different way of looking at efficacy, which found, again, similarity between these treatments. Whatever treatment you select, the thing that really matters is full-time wear. So in all of these particular studies, children were wearing these spectacle lenses or MySight contact lenses full-time, at least 12 hours a day, 6.5 to 7 days per week. So it's really important that we remember that these are not just spectacles or contact lenses, these are a medicine, and the medicine doesn't work if it's not taken. We need the child to wear these to see clearly, but we should encourage them to keep wearing them, even after school, even on the weekend, even if they're low myopes, so they're exposed to the optical treatment of these designs. Now, all of this discussion about describing efficacy 3 ways and then bringing it back to that simple message about categories based on percentage, that's just for you. That's just hopefully a bit of a nerdy science adventure for you. I don't think we need to explain that to parents. I think it can be as simple as this. We can say that there are specific types of spectacles and contact lenses which can both correct myopia and slow down its worsening. We have that dual benefit. And if parents have heard about atropine, we can say, yes, that can help, although your child still needs glasses or contact lenses to see clearly. So why wouldn't we start with those first? They're just as effective as 0.05% atropine and provide both benefits, myopia correction and myopia control. So let's talk a little bit more about these new spectacle lens designs, and all of the publications on these designs have been in this decade, in the 2020s. So there's so much we've learned about these just over the past 3 years. The new lens designs I want to talk to you about are the defocus incorporated multiple segments, or DIMS lens, which is commercialized as Hoya MyoSmart, the highly aspherical lenslet target technology, or HALT technology, commercialized as Essilor Stellest, and then diffusion optics technology, or DOT, which is commercialized as a SightGlass dot lens. Now, these are presented in order of their publications. So the first we heard about in 2020, highly aspherical lenslet target technology. The 2-year data was published in 2020, 1-year data in 2021, 2-year data in 2022. And the diffusion optics technology was published in 2022. Quite recently, there's a publication on another lens, which is being commercialized by Zeiss. So that's using cylindrical annual refractive elements. I haven't got that in my slides today because that's quite a new kid on the block. Now, the difference between these designs is in the optics. The first two employ lenslets, about 1 millimeter in diameter, little tiny lenslets. In the DIMS lens, each of the lenslets is a +350 ad. In the Essilor-Stellest lens, the Holt lens in the middle, the lenslets themselves don't have a discrete power. They're designed to create a volume of myopic defocus. More on that later. And the diffusion optics technology, or dot lens, doesn't use lenslets. It uses 0.1 millimeter diffusers. And these diffusers or microdots are designed to modulate retinal contrast across the retina. So just to explore each of these lens designs a little bit further, this is the DIMS lens. And the DIMS lens has a honeycomb array where there is a space between each of the lenslets. They're not touching. Each of the lenslets is about 1 millimeter in diameter and has a power of about it is a relative ad power of +350. There are spaces between the lenslets such that when the patient looks away from that optical center of the lens, about half of what they see is single vision around and between the lenslets, and about half of what they see is the signal they receive through the lenslets. Next, we have the highly aspherical lenslet target or Holt technology, Essilor-Stellest. Now, the interesting thing here is that these lenslets are designed not to create a +350 or a simultaneous vision correction there. They're designed to create a volume of myopic defocus. So each of these lenslets is aspheric and it creates this volume or this blur of light. So the intent here is to create a large area, a large signal, and sort of an additionally blurred signal, if you think of it that way, for myopic defocus. And each of those rings of lenslets is a different power. So within a ring, the lenslets are all the same power. They're all about 1 millimeter in diameter as well, and they're touching. Then there's spaces between the rings, and each ring is a different power. And you won't, if you try and ask what power of the lens are the lenslets, you won't get an answer, or you'll get an answer in millimeters away from the retina, because it's not a discrete power. It's designed to create this volume of myopic defocus. Now, just to help you get your head around that a little bit more, I just want to explain a bit about our theories of defocus in myopia. And I want you for a moment to imagine a center distance multifocal contact lens, or MySight, which is in the middle there, or Ortho-K, so those little graphics up at the top. Imagine one of those in profile, and in these two images in the middle of the slide, what we're imagining here is a contact lens where those red zones are the peripheral ad zones of a contact lens, or the mid-peripheral steepening zone of Ortho-K. Then we have our little oval, which is our model eye, and then we have our retinal surface at the back. Now, we all understand the concept of peripheral defocus, where a center distance multifocal or MySight or Ortho-K is going to focus central rays on the fovea for clear vision, and then peripheral rays in our peripheral retina fall in front of the retina to create this signal for myopic defocus, this signal for slowdown. But all of these treatments also create on-axis defocus, depth of focus. And this makes sense in terms of a multifocal. We all understand that a multifocal contact lens works to give a presbyope depth of focus. And this is going to happen for a young eye using these lenses as well. So we can't really think about the peripheral or the central retina as being different. It's all retina, and we're going to have this myopic defocus, whether we're thinking about it in the peripheral retina or on axis. So an easier way to wrap those two together is thinking about simultaneous defocus. Essentially, we have some part of the signal coming through the spectacle lens or contact lens falling on the retina to correct vision, and some part of the signal falling in front of the retina as a slowdown signal. And where research is going now is looking at where's the ideal location of this defocus. And the Holt lens, the Essilor Stellest, is designed to create volume rather than two planes of defocus, a volume of defocus, and that to potentially create a stronger slowdown signal for eye growth. Now, the diffusion optics technology lens does not use lenslets. It uses 0.1 millimeter microdots or diffusers. And this is a different theory that is not based on defocus. It's based on contrast. What I would suggest you do, I'll point you towards some further reading you can do on myopiaprofile.com to understand this more, because it's a really interesting new concept, and we've written a little bit about it on Myopia Profile. We don't have any published data yet on visual acuity or visual function outcomes, but we do have published data on myopia control, and it appears to be, based on the 1-year data, similar to what we see with the DIMS or the Holt spectacle lenses. Now, when we're thinking about the DIMS or the Holt spectacle lenses, so that's Hoya MyoSmart or Essilor Stellest, we need to remember that these lenslets aren't creating an add power. And there have been research papers to show that when children wear either of these lenses with lenslets, compared to children wearing single vision, there's no difference in their accommodative lag, their accommodative amplitude, or their near-phoria. So these lenslets aren't being used as an orthoptic add power. They're being used instead to create that simultaneous defocus, that slowdown signal in front of the retina. And when it comes to visual outcomes with these lenses, it's been shown, we've got the most research on visual outcomes, visual function outcomes with the Essilor Stellest, but with the Hoya MyoSmart, which is the first lens, the DIMS technology on the left there, it's been shown that the acuity at distance and near is equivalent to single vision, and there's no impact on binocular vision, vergence or accommodation. That's been shown with the Essilor Stellest as well, but we also have additional data that high contrast distance and near acuity is similar to single vision. Low contrast acuity is reduced by a small amount, by 1 to 4 letters. Reading speed is similar to single vision. Peripheral motion perception is similar to single vision, and field of view and visual field outcomes, some of these tests were done in adults because they're complex, again, is equivalent to single vision. We don't have any of this information yet on the SightGlass dot lens, but there were some posters at the ARVO Research Conference this year showing no impact on accommodation. There has been one paper which compared visual functions in the highly aspherical lenslet design, which is the Stellest, and the honeycomb design, which is the MyoSmart. And these were tested in a repeated measures manner to really compare the lenses directly. And what was found is that visual acuity through the lenslets was reduced in both lenses by about 0.07 logmar in the Holt lens, that's Stellest, or 0.09 in the DIMS lens. So that's 3.5 letters, 0.07 logmar, or 4.5 letters, which is 0.09 logmar. That was significantly different between the lenses, but it's only 1 letter. So it's up to you if you think that's clinically significant. It was found that with both lenses, glare had minimal impact on acuity. So a light source or an oncoming headlight, for example, didn't do much to affect acuity. Low illumination affected acuity a little bit more so. So a lot of similarities and a couple of differences between the two lens designs when tested on the same patients directly. If you want to learn more about all of these designs of spectacle lenses, we've just relaunched the Myopia Profile website and done a huge update on it just at the end of last month. And we have a new section called our Myopia Control Product Compendium, which you can find in the Knowledge Center. You can click on the spectacles part there and learn about specific brands of spectacles, but any of those that you click on will take you to articles that we've written on them, and articles where you can understand more about the science as well as the clinical application of these lens designs. So I think there are a lot of benefits of myopia controlling spectacles. And I know that I was very excited once they became available, because sometimes kids aren't ready yet for contact lenses. And We had a lot of contact lens options. Now we have spectacle options to match. We have strong evidence of myopia control efficacy with these designs. They appear to have minimal impact on acuity or binocular vision function, although we don't have that data yet on the cyclast dot lens, and they are easy to prescribe and fit. So hopefully that gives you a bit more understanding about our new spectacle lens designs, and the new the cylindrical annual refractive elements lens, which is being commercialized by Zeiss's MyoCare. We'll publish a review on that on myopiaprofile.com in the coming weeks. So if you're connected to us through our email list, which you can subscribe to from the footer of any page of myopiaprofile.com, or if you're connected with us through the Myopia Profile Facebook group, we'll keep you up to date on that. So finally, I want to talk to you about red light treatment. And this is fascinating. And this was absolutely a hot topic, hot literally and figuratively, perhaps, at the ARVO Research Conference this year. So the red light treatment was pioneered in China. And essentially the concept of it is to get a pair of eyeballs exposed to an equivalent brightness that they could get outdoors, but without going outdoors. Now, that might sound a bit of a depressing concept, that we're trying to cheat and not get kids outdoors, but in China, it might not be as easy to get kids outdoors as perhaps what it is here in Australia, for example. Now, this red light treatment is, it's designed to look like diffuse light, but it's laser diodes that are viewed for 3 minutes a day, 3 minutes twice per day, separated by at least 4 hours, and the clinical protocol was for 5 days a week. And it's plugged into the internet and to a login, so it's not possible to overuse it, to use it too much. And that was a way they were able to monitor compliance in the study as well. Apparently, the instrument has been used for amblyopia treatment in China, although I couldn't find any published papers on that. And it has been declared a class 1 laser considered safe for direct ocular exposure. That being said, there is some concerns about potential long-term safety. And so this is where we're learning more about how this treatment works. Now, the red light clinical trial results were very impressive and should definitely make us sit up and take notice. The 1-year results were extremely impressive, and they showed a myopia control effect in excess of 2/3. So it slowed axial growth by about 66%. That millimeters there is about 1 diopter, so about 1 diopter saved just in a year. And the actual diopters measured, you can see they're 0.59. The difference between that and the millimeters is essentially because diopters are a blunter measurement tool, so we can measure finer changes in myopia progression with millimeters. In the 2nd year, the control effect was about half. So again, we're getting closer back towards our optical treatments we talked about earlier. But concerningly, there was a group there, that orange line were kids who had the red light treatment for 1 year and then went back to single vision, and they had a significant rebound effect. Their eyes grew 0.42 millimeters in a year, compared to the single vision wearing kids who'd had no treatment, whose eyes grew 0.28 millimeters in a year. So excessive axial eye growth is concerning for retinal health. What was absolutely fascinating and had everyone talking at ARVO was a presentation that measured axial length shortening in a percentage of kids. So we're not talking about slowing down eye growth, we're talking about shortening compared to baseline. 0.05 millimeters could be within tolerance of measurement of axial length, but 15% of kids had eyes that were 0.1 millimeters shorter than at baseline, and 6% of kids had eyeballs that were 0.2 millimeters shorter than at baseline after 12 months. And that's mind-blowing because we don't understand the mechanism of that. Only about 1/3 of that appears to be due to choroidal thickening. So that unknown mechanism is intriguing and potentially, according to some researchers, could be concerning as well. And there has been a case report in the literature of retinal damage due to red light therapy. This was a child who had undergone red light treatment for 5 months and presented with bilateral vision loss. Her acuity had degraded from 6.6 OU to 6.9. A full workup showed no inflammation in her eyes or generally, and with cessation of red light treatment, her eyes acuity recovered, perhaps arguably not the whole way, to 6750U. In the case report, what was shown was these particular findings. So bilaterally darkened foveae with hypoautofluorescent plaques and some changes in the foveal zone on OCT. Now, this is one case report, and the clinical trial said that the kids were monitored with OCT and found no changes in retinal health. And this indicates that we still need to learn more. And I wonder if this could potentially end up like the early days of Ortho-K, where we have clinical trials where things are fitted well and controlled well and it's safe, but then we also had some problems with it being used in a certain way and it not being safe. Perhaps there are some young eyes which are more susceptible to phototoxicity, so to suffering from light exposure. There's more that we need to learn about this. And if you want to read more about it, we've written an article on it, believe it or not, on myopiaprofile.com, published that quite recently, where we reviewed the clinical trial, which said it was effective and safe, and also that case report at the same time. So have a look for that if you want to read more about this topic. I think at the moment we have a lot of fantastic optical treatments available to us, or if you have atropine, 0.05% based on the current studies appears to be most effective. And it makes sense to me that we would stick with these treatments where we have long-term safety data and long-term efficacy data as well at this point. But this is definitely something for us to keep our eyes on and to understand more about as the science develops. So I just want to finish up now with some resources to help you in practice. The International Myopia Institute, I'm sure you know about, is a global consensus group of well over 100 academics and clinician-scientists, and we've put out 3 volumes of reports. The first was in 2019, and that was my baby there, the Clinical Management Guidelines report. Then in 2021, there were further full reports, and the IMI Yearly Digest is where the previous reports were updated. If you go to myopiainstitute.org, you can get shorter versions of these, so you don't have to read the full papers. So that's a good place to go to get the lowdown. But back in May, we had publications of our 2023 volume of papers. And the 2023 digest features about 2,000 words from yours truly, from myself, my co-author, Pauline Kang, where we're talking about what clinical translation of myopia management looks like right now in 2023. And in the 2023 volume of papers, this 3rd volume, there are also new papers on onset and progression of myopia in young adults. Very important topic, and one for which we have data, but perhaps not as much data as we'd like for practice. We do see these patients in practice. Important papers on high myopia in infants and young children, understanding the science of the choroid, human tissue, ocular tissue changes, the global survey, which has been repeated 3 times now to understand myopia management attitudes and strategies, and updates on the 2019 papers. So if you just Google IMI 2023 Digest, you'll get there and you'll be able to read those updates, and in particular, the Clinical Management Guidelines update. Now, myopiaprofile.com and mykidsvision.org are what I spend all of my time on now, developing resources to help you in practice. So myopiaprofile.com is designed to support you and your learning. There are free resources to download on there, such as our Managing Myopia Guidelines infographics and informed consent templates. And mykidsvision.org is designed to support you in clinical communication. So you can point parents towards that. You can also utilize the Facebook and Instagram posts and share those onto your practice social media platforms. Myopiaprofile.com is for you to help you in learning more. There are online courses, as Fethu was mentioning at the outset, and there are lots of resources to help you not just learn, but to also put this into practice, to see that practical translation. mykidsvision.org is for parents to learn about myopia management, hopefully before they come to you, or for you to direct them to it when they come to you. And what we've done is divided the information in mykidsvision.org into age categories, so parents can read information specific to their child's age. What you see on the right of the slide there is a mykidsvision.org QR code sheet. And this is available in the resources section on myopiaprofile.com, because this is a resource for you. You can download and print this, and this QR code will direct parents to specific articles on mykidsvision.org. So you've got something ready to go to be able to direct them to further reading on the visual environment, or spectacles, or contact lenses, or expectations in myopia control. That's free to download and free to print. At the moment, that's just available in English, but we're working on lots of various translations of both of our websites. Finally, I want to tell you about Myopia Action Month and ask you to join in. This is a new global event which we have championed. We have 9 industry sponsors who are working with us to make this happen as well. And Myopia Action Month is designed to take all of this awareness we have and really translate it into action, to give you practical tools to get started, or if you've already gotten started in myopia management, to take your next steps to expand what you're doing, expand your knowledge, and expand what you're offering to your patients. So check out the website myopiaaction.com. You can also find it from the homepage of myopiaprofile.com, and stay tuned, because we've got lots of new resources and mini seminars, lectures to come for you in September. On that note, I want to thank you so much for your attention. Thank you for the invitation, and I'll be happy to take any questions. Thank you very much.
Thank you indeed. That was a very nice lecture. I personally learned a lot of things. I think that it's the most updated lecture I have attended this year. Thanks a lot.
Thank you.
I will start from because I'm living in Algeria. There is a design which it wasn't mentioned in your talk. It's called focal lens. It's like the Micon for the stock. I don't know. I think it's the Russian design, which was it has been. I think it has been at one time. It has been also studied in Bain-Howden Institute, Vision Institute, and it is today it's labeled here in Algeria MyoLife, which is a perifocal design. It's just on the horizontal axis. It's not the same design as the one of Zeiss.
Correct. Yeah. And so this lens does not have the same level of data on it as DIMS or HALT or the dot lens, or even the new care lens, the Zeiss MyoCare lens. So there's one published paper on it. The axial length data is difficult to interpret. So it's very hard for us to understand how well that works in comparison to look at how that could work in comparison to current treatments. We don't know what the visual outcomes are. And the thing about these designs with lenslets or with diffusers is that we know that the acuity is good through the periphery of the lens. We have published data on that. But this lens is designed to give a peripheral add. So we're getting out to, 1.5, 2 diopters of add across the horizontal. And so we can't expect that acuity is going to be as good when someone is looking through a relative blur of 2 diopters. So it is a lens that's readily available, but the data isn't the same as the data I've presented to you today with these other lens designs. And we don't know what the visual function will be like and how well it will be tolerated. So it might be perfectly fine to look through straight ahead, but in the periphery of the lens, there's going to be a lot more effective defocus. From a visual experience point of view for the wearer, it's likely to be harder to wear, I think, than the current designs where we have that data available.
Okay, thank you for the comments. Is there any question from the audience?
Good evening, Kate. I want to ask you, can you hear me?
Yes,
Yeah?
I can.
Okay. Do you have experience maybe using this kind of spectacle lenses for ametropic children, but who is in risk of myopia because of parents, or maybe with increased axial late, but at the same time when sphere equivalent still normal, still ametropic? So maybe you have some experience. Start with MyoSmart Planum, for example, and yes, this is
Yeah, look, it's a very good question, and it's definitely something that we could consider. So there's no research on how well these lenses, these spectacle lenses, could do in delaying onset of myopia. And the challenge there essentially is in compliance. And if we have a child who has perfect vision and perfect acuity, how compliant are they likely to be with a pair of these spectacles? So I haven't personally done it. I have instead talked to parents about increasing time spent outdoors. Unfortunately, sometimes it's a lot easier to prescribe a thing than to prescribe a change in behavior, like spending increased time outdoors. But we do have evidence for that. There's an enormous evidence base that increasing time spent outdoors can delay the onset of myopia. The only other treatment at the moment that has evidence for delaying onset of myopia is atropine 0.05%. So atropine 0.01 and 0.05 were compared in a recent study to a placebo, and 0.01 didn't delay onset of myopia, but 0.05% did. So it's definitely something you could look at trying. It would just be a question of having a very motivated parent who really understands what we're aiming for, and having a child who would be compliant with wearing the spectacles.
I asked because I listened to a webinar of Dr. Kaimak, and he explained that we have so-called silent myopia in junior children when they already have increased axial late, but at the same time maybe of lens or cornea refractive adaptation process, we still have sphere equivalent as ametropic. So maybe for these children, we can somehow explain or motivate parents to use Planum lenses, and maybe in this case, we can avoid myopia at all in these cases. That's why I asked. Thank you.
Yeah, absolutely. That would be the goal. What has just popped into my head as you've said that, and mentioning Dr. Kamak's lecture, a very important point is that the fastest change in refraction and the fastest change sometimes in axial length occurs just before myopia onset. So if you are measuring, if you've got some really good, consistent, accurate refractive data or axial length data that shows a fast change, say in millimeters, but the child is still ametropic in diopters, then that can definitely be something to motivate a parent, because we can see that quick change occur just before myopia actually onsets in diopters. So absolutely, yeah.
And maybe last remark, sorry, I waste your time, nevertheless. When you talk about this red light therapy and these impressive results as a shortening, maybe if they maybe this shortening of axial late could be only for younger children, till 12 years, till maybe 10 years, because of this ametropization maybe still can cover axial elongation. So
Yeah, that's an interesting thought. I'd have to go back to look at the paper. Oh, actually, the axial length shortening data was just an ARVO abstract presentation, so it hasn't been published as a full paper yet. I don't believe there was an effect of age. That would be the thing to look at, whether it was more likely to occur in younger or older children. I can't quite remember the sort of subgroup analysis because it wasn't published. It was just mentioned there. It might have been something to do with higher myopes. What they did is measured choroidal thickness and found that thickening of the choroid only accounted for about 1/3 of this axial length shortening. So something else is occurring, and we're going, well, what is the something else? Is it thermal? Is it, something like a scarring effect? What's happening? And is it, if it's not just to do with measurement, because we've got very accurate measurement instruments, then what else is occurring? Perhaps the young eye, as you say, it is very plastic to change. And perhaps that is the case that's occurring. I guess we'll know more about that when the research that was presented at ARVO, if that is published.
Thank you very much.
Thank you for good questions.
I don't know if there are other people who would like to ask questions to Kate.
If you're not brave enough to ask out loud, you're welcome to contact me on Facebook or LinkedIn, or my email is kate@myopiaprofile.com as well.
Okay, so thanks a lot, Kate. I think that we'll let you go to bed. It's 5:30 in Brisbane. It was a really a great moment to share with you and to learn from you. I am looking forward to read again and to look at the Myopia Profile, which is a kind of school and kind of also encyclopedia for this new topic, which is giving us sometimes some doubts, and there's still some controversies, we must say, but I think that everything which is going further will have some hesitations at the moment, because we have to see what is happening. I would like just to comment about red light. I think that it's this year that there are some papers which has been published, and it's a new way to try to slow the elongations, which has the fact that it is giving it is shortening the axial length. It seems that it could be some kind of adverse effect, and because when we are thinking about axial length, we are thinking about retina, also about choroid and sclera. That's the whole point. So if we don't know what is the action actually of the red light on the photoreceptors or on the ganglion cells and so on, so we don't know what is happening at all. We do know that for the optical side, that diffuse hyperopic diffuse is generating elongation of the axial length. So we know that when we are using specs or using contact lenses, we are not at all harming any kind of a tissue inside the eye of the human being. So we have to be careful about red light, about using laser and so on. We have, I think we have to focus on this new designs. We have to wait for to see in maybe in 2-3 years what would be the results for this young kids which has been benefiting there's a new designs. I think all the design are aiming to have a result. So the only problem I think is that in some areas of Earth, from an underdeveloped country, it's not obvious to find either DIMS or Stellest. So we have some kind of solution, bifocal with prisms, maybe some other designs which has not have all the background such as the Stellest or the DIMS, such as this perifocal, which will try to even to help young people to avoid high myopia and all the damage which can occur. We are seeing in our practice every day some of these pathologies, and we are very sorry for these people. But if we could help some young people to avoid to have this mess and this damage, it's important. Thank you. Thanks a lot.
Absolutely. Thank you.
Our next webinar will be with Mr. Lorcan Butler. It would deal with the papilledema and optic nerve and papilledema. Donc, ça va être sur l'œdème papillaire, sur le nerf optique et l'œdème papillaire. Ça va être le 24 de ce mois, à la même heure, donc jeudi prochain à 19h30. D'ici là, je vous souhaite bonne continuation. So next webinar will be on Thursday, 24th of August at 7:30, at the same time as today. Meanwhile, I will wish you good health and carry on working hard to improve the knowledge of about all these topics. Thanks a lot.
Thank you. Merci. Thank you, everyone. Goodbye.
Goodbye. Thank you, everyone.